Hello everybody. Today we are going to discuss the question which was asked in DRNB Critical Care Exam November 2020. The question was discuss the diagnostic workup and the clinical management of 27-year-old primary gravida who is deeply icteric and presents with the generalized condition. So here what they are asking is to what they are asking is the management of the eclampsia. So we will see the eclampsia in detail. So hypertensive disorder of the pregnancy affects approximately 5% to 10% of pregnant females. Preeclampsia and eclampsia accounts for approximately half of these cases worldwide. These conditions are responsible for up to 14% of all maternal deaths. One of the primary pathophysiological outcome of the uteroplacental ischemia in preeclampsia is the release of pro-inflammatory cytokines and the anti-angiogenic factor into maternal circulation, leading to the endothelial dysfunction. So endothelial dysfunction is directly leads to disruption of the blood-brain barrier by causing by increasing its permeability, resulting in an imbalance of iron, neurotransmitter, and metabolic products into interstitial fluid. So this anti-angiogenic imbalance may also perturb the myogenic tone of the vascular smooth muscle, and uncontrolled vasoconstriction may cause abnormalities in the autoregulation of cerebral circulation. Since the maintaining the homeostasis of the brain environment is crucial, both hypoperfusion and hyperperfusion may cause significant harm. Insufficient cerebral blood flow may result in regions of ischemia and brain injury. Hyperperfusion, on the other hand, combined with blood-brain barrier dysfunction, may result in vasogenic edema. Eclamptic seizures are the result of edema and dysregulation of neuronal microenvironment due to blood-brain barrier breakdown. Now, the diagnosis of eclampsia. Preeclampsia is defined as new onset hypertension, that is systolic blood pressure of more than 140 mmHg or diastolic blood pressure of more than 90 mmHg at or after 20 weeks of pregnancy, and coexistence of one or more of the following new onset condition, that is significant proteinuria, maternal organ dysfunction, and uteroplacental dysfunction. Eclampsia is the convulsive condition and most severe manifestation of preeclampsia. It is defined as new onset tonic-clonic seizure activity, usually lasts for 60 to 90 minutes, and or coma in the absence of other causative conditions. In some cases, either hypertension or proteinuria are absent. Studies have shown that over one-third of eclampsia cases occur suddenly without any preceding sign and symptom of the preeclampsia. However, up to 83% of eclampsia cases are linked to prodromal symptoms before seizure occur. These include neurologic symptoms such as severe and frontal or atypical headache, generalized edema, vision disturbances, amnesia, non-neurologic symptoms such as right upper quadrant and epigastric pain. Vision changes may include blurry vision, scotoma, photopsia, diplopia, and transient blindness. Unfortunately, these symptoms cannot definitely confirm or exclude the diagnosis, and in many cases, the patient may be unable to provide history due to being altered or actively seized. The onset of eclamptic convulsion can be in the antepartum, intrapartum, and postpartum period. Although the definition includes the symptom and signs past 20 weeks of gestation, almost all cases of antepartum eclampsia will occur after 28 weeks of gestation. Eclampsia can occur before 20 weeks of gestation in patients with a renal disease, molar pregnancy, and multiple gestation. About physical examination finding in eclampsia can vary. Common findings include hypertension, tachycardia, tachypnea, mental status changes, edema, clonus, hyperreflexia. Accurate blood pressure measurement with appropriate size cuff is crucial, although the severity of hypertension does not predict eclampsia. About 20% of eclampsia cases occurs with mild hypertension, and the blood pressure may be normal in 25% of patients. About lab feature, although eclampsia is a clinical diagnosis, lab tests are recommended to evaluate disease severity, complication, and other possible or concurrent causes. Once initial evaluation is performed, appropriate management is then guided. Lab evaluation includes blood cell count, renal and liver function panel, electrolyte, glucose, coagulation panel, fibrinogen and lactate dehydrogenase, uric acid, and urine analysis. Thrombocytopenia, elevated creatinine, elevated aminotransferase, elevated LDH, uric acid, and proteinuria may be revealed. HELP syndrome, whose acronym is derived from the symptomatic triad, hemolysis, elevated liver enzyme, and low platelet count, represents a complication of severe preeclampsia and is diagnosed on the basis of biochemical lab evidence. Its diagnosis should be ruled out because of the high mortality during pregnancy and the postpartum period. In addition to the eclamptic seizure, preeclampsia is associated with other neurological complications such as cerebral venous sinus thrombosis, reversible cerebral vasoconstriction syndrome, posterior reversible encephalopathy syndrome, subarachnoid hemorrhage, intracranial hemorrhage, and arterial ischemic stroke. Neurological complications during pregnancy and postpartum period often overlap significantly, making it difficult to distinguish between them due to their many similarities. Therefore, patients with the new onset seizure, altered mental status, or focal neurological deficit should undergo non-contrast CT and MRI to check for intracranial issues. Furthermore, patients with the cardiovascular and respiratory symptom should undergo ECG and chest radiography to evaluate for dysarrhythmias, right heart strain, pulmonary edema, and pneumonia. Now, management of eclampsia. Management of eclampsia uses team-based approach that involves obstetrician, anesthesiologist, labor, and delivery nurses. Definite treatment of the eclampsia is the delivery of the fetus as soon as woman is stabilized. But supportive care during seizure is as soon as convulsion is clinically diagnosed, foundational emergency treatment should be provided for stabilization. So first step is to assess and establish airway and ensure oxygenation. Administering oxygen delivery is crucial for maintaining proper saturation levels and treating hypoxemia that occurs from hypoventilation during the seizure activity. An oxygen flow rate of 8 to 10 liters per minute through facial mask provide more than 60% of oxygen concentration in breathing mixture and reduces the risk of respiratory acidosis. If oxygen saturation falls below 93% by pulse oximetry, it is necessary to assess the artery ABG and administer bicarbonate in cases of acidosis. After seizure has ended, the patient usually starts to breathe normally and does not need supplementary oxygen. However, in women who have repetitive seizure, aspiration pneumonia and pulmonary edema may lead to maternal hypoxia. The patient should be placed in the lateral decubitus position to decrease the risk of aspiration of gastric content into respiratory system and improve the uterine blood flow by relieving obstruction of vena cava by gravid uterus. Furthermore, oral secretion should be suction as needed. Cardiac monitoring is deemed necessary to ensure the ongoing assessment and surveillance of cardiac function and rhythm. During convulsion, the aim is to prevent maternal injury during seizure. For this reason, the bedside rail should be elevated and padded. If possible, intravenous line with 16 to 18 gauge catheter should be already present before seizure to administer necessary medication and to maintain fluid and electrolyte balance. Fluid management is crucial in patients with eclampsia because volume expansion can lead to fluid overload and pulmonary edema. Fluid restriction can worsen tissue hypoperfusion and renal function. So fluid assessment should be individualized based on IVC, pulse pressure variation, and stroke volume variation. Now about the treatment of convulsion. Next step in the management of the eclampsia is the prevention of recurrent seizure. Magnesium sulfate is the drug of choice for preventing recurrent convulsion in the female. In 1995, Eclampsia Trial Collaborative Group reported that magnesium sulfate significantly reduces the risk of recurrent seizure compared to other anti-epileptic agents. In 2002, MACP trial demonstrated that female with as soon as a convulsion is clinically recognized, foundational emergency treatment should be provided for stabilization. Now, the mechanism of action of magnesium sulfate. One possible mechanism is improvement of both placental circulation and vascular response to dilator by enhancing nitric oxide synthetase activity and maintain the balance between angiogenic and anti-angiogenic growth factor. Apart from being vasodilator, magnesium sulfate also acts as central anticonvulsant by increasing the seizure threshold after inhibiting NMDA receptor. Furthermore, magnesium as a catch-up antagonist can affect cerebral endothelium by protecting blood-brain barrier and reducing formation of cerebral edema. Magnesium sulfate is the first-line treatment to control eclamptic seizure. Loading dose of 4 to 6 grams should be administered IV over 15 to 20. Convulsion usually stop after loading dose. Maintenance dose of 1 to 2 gram per hour should be administered as a continuous IV solution in order to prevent recurrent seizure. Female with the BMI of more than 35 kg are significantly more likely to reach therapeutic serum magnesium concentration when given 6 gram IV loading dose followed by 2 gram per hour IV maintenance dose compared to those receiving 4 gram loading dose followed by 1 gram per hour maintenance IV dose. In patients who do not have available intravenous access, magnesium sulfate can be given by intravascular injection. Loading dose is 10 gram and the maintenance dose is 5 gram every 4 hours. The serum level fluctuates more with this regimen than with continuous IV solution. Approximately 10% of the female experience second seizure after receiving magnesium sulfate. The second bolus of 2 gram of IV magnesium sulfate can be administered to these women for 3 to 5 minutes. In rare cases of recurrent convulsion, despite adequate and therapeutic doses of magnesium sulfate, the recommended dose is 4 mg lorazepam administered IV within 3 to 5 minutes. The main symptoms are hypotension secondary to the reduction in systemic vascular resistance, facial flushing, and flushing at the injection site, increased warmth and sweating due to peripheral vasodilatory effect of magnesium. Visual disturbances can occur, chest pain and nasal stuffiness. For female who are treated with cardiac glycoside or digitalis, magnesium sulfate should be administered with caution as digoxin can induce hypermagnesemia with several important clinical consequences. Additionally, concurrent use of magnesium sulfate and depressant may result in enhanced CNS depression. Magnesium sulfate should ideally be infused 2 hours before fetal delivery due to possible interaction with neuromuscular blocking medication given intraoperative. In patients with neuromuscular disorders like myasthenia gravis, neuromuscular function can deteriorate even at low medication concentration. Therefore, the use of magnesium sulfate is contraindicated in this disease. Other contraindications include severe hypocalcemia, complete heart block, and myocarditis. The therapeutic blood level of magnesium are 4 to 7 milliequivalent per liter. As this level continue to rise, finding of toxicity start to manifest. Patient develop muscle weakness and loss of deep tendon reflexes at serum level of 8 to 10 milliequivalent, while respiratory depression occur at 15 milliequivalent. Additionally, patients experience ECG changes at 5 to 10 milliequivalent. Signs of abnormal conductivity surface as sinoatrial and and atrioventricular node block at 15 milliequivalent per liter and high risk of cardiac arrest at 20 milliequivalent or higher. However, there is no need of routine monitoring of magnesium level except for female with renal impairment and electrolyte balance. So magnesium is excreted almost exclusively by the kidneys. Consequently, there is increased risk of magnesium toxicity under this condition. The loading dose does not change in the women with the serum creatinine of more than 1.5 per. It is also necessary to monitor reflexes, creatinine function, and urine output during administration of magnesium to prevent toxicity. The maintenance dose should be given only if tendon reflexes are present and the respiratory rate is more than 12 per minute. The urine output exceeds 100 ml in 4 hours and therapeutic blood levels are within normal range. At first sign of toxicity, both magnesium sulfate administration should be discontinued and excessive magnesium is removed from the body. In patients with the normal kidney function, this can be achieved with intravenous diuretic, while dialysis treatment is necessary for those with impaired kidney function. In severe cases, antidote can be used to displace and neutralize the effect of magnesium. The antidote is 10 ml of IV solution of 10% calcium gluconate given for the 5 minutes. In addition to antidote, emergent intubation may be required in female with increased risk of respiratory depression. Calcium gluconate should be given with caution because it may precipitate heart. In women with the impaired renal function or signs concerning magnesium toxicity, the measurement of magnesium in the blood is recommended every 4 to 6 hours. Infusion should be paused if serum level exceeds 8 milliequivalent and restarted at low rate when the serum level decreased to less than 7. Importantly, the administration of magnesium should be continued for 48 hours after delivery and at least 24 hours after last consumption. Approximately 10% of patients do not respond to magnesium and require IV administration of diazepam at a dose of 5 to 10 mg and or phenytoin at a dose of 250 mg within 12 hours. Therapeutic level of phenytoin is 12 mg per. Women with the myasthenia gravis should be treated with levetiracetam or valproic acid because magnesium and phenytoin causes the muscle weakness that can be followed by myasthenia crisis. Treatment of hypertension. The aim is to maintain systolic blood pressure between 140 to 160 mmHg and diastolic blood pressure between 90 to 110 mmHg. So caution must be taken not to reduce the blood pressure too drastically due to risk of sudden decrease in the blood flow to the maternal organ, including uteroplacental circulation, which can lead to fetal hypoxia and even intrauterine fetal death. So the mean arterial blood pressure should be decreased by 15 to 20% in patients with severe hypertension. So first-line pharmacological treatment for hypertension include labetalol, hydralazine, and nifedipine. IV administration is necessary in unconscious patients. The choice of antihypertensive drug should be individual. So first, we'll see what is labetalol. Labetalol is the mixed alpha-adrenergic and beta-adrenergic antagonist, causes vasodilation and the reduction in the heart rate. Initial dose is 10 to 20 mg IV slowly for 2 minutes, followed by 20 to 80 mg every 20 to 30 minutes, to the maximum dose of 300 mg in 24 hours. Is recommended until target blood pressure is reached. Mechanism of action of labetalol involves reducing peripheral vascular resistance without compromising blood flow to the brain, periphery, coronary, and renal system. A non-selective beta blocker, it should be given with caution in female with the mild to moderate asthma and is contraindicated in female with the severe asthma. Other contraindications include congestive heart failure, left ventricular dysfunction, AV heart block due to risk of bradycardia. The risk of neonatal bradycardia and hypoglycemia may also be increased with the labetalol. Caution should be exercised in female with the history of impaired liver function as severe hepatocellular injury is recorded. Very rare complication. Hepatotoxicity may be confused with the HELLP syndrome. Most cases of labetalol-induced liver toxicity are reversible, but death has been reported. Now, the next drug is hydralazine. Hydralazine causes dilatation of the blood vessel, leading to the reduction in peripheral vascular resistance and the blood pressure. IV bolus of 5 to 10 mg over 2 minutes and 10 mg IV followed by 5 to 10 mg after 20 minutes up to total dose of 20 mg IV or 30 mg IM should be given if SBP is greater than 160 mmHg and diastolic blood pressure is greater than 110. Hydralazine should not be used in the presence of tachycardia greater than 100 beats per minute because of short-term adverse effect in the form of reflex tachycardia and heart pounding. Labetalol is preferable to hydralazine because it has quicker onset of action and a lower risk of reflex tachycardia. Sudden drop in the blood pressure may occur, leading to significant reduction in uteroplacental blood flow, disrupt heart rate, and fetal bradycardia. Caesarean section rates have increased secondary to fetal distress caused by pulse disruption. Besides maternal hypotension, other possible side effects include headache, chest pain, dizziness, reduced urine output, and high incidence of placental abruption. Alternatively, oral nifedipine may be administered, particularly when IV access has not been initiated. Nifedipine is the dihydropyridine calcium channel blocker that promotes vasodilation and reduces the systemic vascular resistance. A starting dose of 10 mg immediate release nifedipine should be given repeated every 20 minutes up to maximum daily dose of 180 mg. Nifedipine should be administered as a tablet or capsule, and each of which should be swallowed whole, not bitten or punctured. Nifedipine should not be given sublingually because of possible irreversible severe hypotension with consequent severe maternal and perinatal morbidity and mortality. Tachycardia, flushing, peripheral edema, dizziness, headache are the main adverse effects. Furthermore, combining calcium channel blocker with magnesium sulfate requires caution because it could cause neuromuscular blockage and uterine relaxation, although these effects are very rare. Second line alternative for treatment of resistant hypertension include the use of nicardipine and esmolol via infusion pump. Sodium nitroprusside and nitroglycerin should be reserved for extreme emergency and used for short-term amount of time. They contain cyanide and have potential to cause maternal, fetal, and neonatal cyanide and thiocyanate toxicity and increase intracranial pressure with potential worsening of cerebral edema in female. Diuretics are not often used in eclampsia and condition characterized by lower plasma volume because they may further reduces the volume depletion and cause reactive vasoconstriction. They are used only in cases of pulmonary edema prior to delivery. Methyl dopa alpha 2 adrenergic agonist is safe antihypertensive medication during pregnancy but is less effective than beta blockers and calcium channel blockers. Angiotensin converting enzyme inhibitor and angiotensin 2 receptor blocker are recognized teratogen that causes adverse effect on developing fetal renal system such as emerging kidney injury and oligohydramnias. They have also been associated with skull anomalies and they are contraindicated throughout the pregnancy. Now the management after conception. Maternal monitoring include respiratory rate and oxygenation, heart rate, blood pressure, fluid intake and the urine output, neurological status for signs of increased intracranial pressure or bleeding. In cases of signs of pulmonary edema, oliguria, anuria, monitoring of the pulmonary arterial blood pressure is indicated. If initial lab results are normal, no repeat is needed after seizure. Conversely, if results have shown thrombocytopenia, lab evaluation should be repeated in 6 hours. Platelet count and the kidney function need to be stabilized before delivery. In stable non-bleeding patient, platelet transfusion is recommended if platelet count is less than 50,000 before cesarean and less than 20,000 before vaginal. Antenatal corticosteroids are recommended for pregnant female between 24 weeks or 36 weeks of gestation because they help in lung maturation and generally improve neonatal outcome. A dose of 12 mg IV betamethasone or 6 mg IV dexamethasone should be administered in anticipation of emergent delivery. Fetal monitoring may reveal changes in the fetal heart. These heart rate abnormalities are related to maternal lactic acidosis caused by intense vasospasm and uterine hyperactivity during convulsion, leading to reduced uteroplacental blood flow and fetal hypoxia. Despite these fetal heart rate changes, emergent operative intervention is not indicated for these transient bradycardia because of its spontaneous resolution. The primary focus should be on maternal oxygenation and stabilization. Growth restricted and preterm fetus may have prolonged recovery time after seizure. Continued uterine hyperactivity and persistent fetal bradycardia may indicate a placental abruption, which needs further management. Definitive treatment, as I mentioned, is delayed. Now, postpartum eclampsia. Postpartum eclampsia and eclampsia typically presents within 48 hours after delivery, with highest risk extending through first week postpartum. Late postpartum eclampsia, on the other hand, should be considered in female who develop new onset hypertension between 48 hours and 6 weeks after delivery. So 48 hours has traditionally been used because it typically covers immediate postpartum changes. Magnesium sulfate is recommended in new onset postpartum preeclampsia with any neurological symptom, particularly in the first week after delivery. Similar to antepartum eclampsia, management of severe hypertension is also important due to increased risk of maternal morbidity. As there are no fetal concern post-delivery, treatment can be initiated at lower threshold, such as 150 to 100 mmHg, to prevent severe hypertension. First-line antihypertensive agents used are similar to those used during pregnancy, including IV labetalol, IV hydralazine, and oral nifedipine. So this is the schematic representation of the management of the eclampsia. So first is emergency care, which includes stabilization of the airway, proper oxygenation, lateral decubitus positioning and suction, monitoring of the heart rate, blood pressure, establishing IV access, avoiding maternal injury. Then for our primary goal is to prevent the seizure. For prevention of seizure, the choice of drug is magnesium. Loading dose is 4 to 6 gram IV over 15 to 20 minutes. Then maintenance dose of 1 to 2 gram IV every per hour. If no IV access is available, then we have to give the magnesium by the intramuscular dose, that is loading dose of 10 gram, 5 mg in each buttock, and maintenance dose of 5 gram IM every 4 hours. Then next time is to control blood pressure. That is for controlling blood pressure, three drugs are recommended. That is labetalol, hydralazine, and nifedipine. Labetalol is given in the dosage of 10 to 20 mg IV slowly for 2 minutes, followed by 20 to 80 mg IV every 20 to 30 minutes. Hydralazine 5 to 10 mg IV every over 2 minutes, and 10 gram IM followed by 5 to 10 mg after 20 minutes. Nifedipine 10 mg immediate released 10 mg immediate release and then uh, repeated every 20 minutes. Then for the recurrent seizure, we need to consider second bolus of 2 gram IV magnesium sulfate, and if a seizure is not stopping, then IV lorazepam. And then if the definitive treatment is delivery. Thank you, friends.